Hi, good afternoon. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn, Thursday afternoon, 12:30. We are really excited today to have our Chairman of Medicine talking to us, Dr. Larry Friedman. He's going to be giving us an update on viral hepatitis 2021. Many of you know Larry from his clinical work, and his talks are always a pleasure. So we are so excited to have him on our little shindig here in the afternoon. Hopefully the pictures won't be as graphic as they were last week in the dermatology, and you can enjoy your lunch and learn at the same time. Next slide, Larry, please. Just want to quickly tease upcoming lunch and learns. I'm going to take only 3 seconds because I want him to have as much time as possible. Here are the upcoming talks. Remember, they're all archived up on YouTube. Next slide. Wanted to talk about our Newton-Wellesley Orthopedic Walk-In is now open, and check out the hours, 8 to 8. No appointment is necessary, Monday to Friday. All typical orthopedic injuries. There is a phone number there for appointments, and on Saturday and Sunday, 7 days a week, right at our 978 location. Next slide. And here is a list of certain injuries that they'd see. Remember, we have full-on x-ray, casting, and bracing right there at the same site. The patients can avoid the emergency room. Next slide. And just quickly, a quick plug for physician care concierge services. I myself have used this now, I think, up to 3 times, looking for someone to fix your air conditioning or your heat, someone to clear the snow from your driveway. All these folks do is they just send you an email with 3 or 4 people in your area who are in your budget, who can do the job for you, and they've been vetted, and then you just call them. No pressure. Very simple. You can sign on. Just go to the website on the bottom, register, and welcome code NWH. It costs you $0. Next slide, all yours, Larry. I'll stop talking now. Thank you.
Well, thank you, John. First, I want to congratulate you on receiving all of the partner Pillars of Excellence team awards yesterday.
Thanks, Larry.
I'll be talking about viral hepatitis, and after putting my slides together, I realized there was too much to cover in one session. So we'll divide this into 2, and I'll give the second session at the end of April. And that will cover hepatitis C and E. This session will cover hepatitis A, B, and D. Now, these are my disclosures, nothing relevant to this talk. So this has been an incredibly exciting field to follow over the past 40 years. The advances have been stunning. We've gone from just identifying the viruses to being able to treat and in some cases cure the viral illnesses. As you all know, there are 5 hepatitis viruses conveniently designated A through E. They're all RNA viruses except for hepatitis B, which is a remarkable agent, very compact, and 3 of them are enveloped and are associated with chronic infection. 2 Nobel Prizes have been awarded for the discovery of hepatitis viruses, hepatitis B and C, and the most recent was awarded this past year to Drs. Houghton, Rice, and Alter for the discovery and development of therapies for hepatitis C. So viral hepatitis is a major preventable cause of death. In the pre-COVID era, it was the #2 infectious cause of death in the world. And in undeveloped countries, it's still a major source of morbidity and mortality. There is a differential diagnosis to viral hepatitis, shown on this slide. In addition to the conventional hepatitis viruses, other viruses, including the SARS-CoV-2 virus, can cause a picture that looks like viral hepatitis. One always has to think of drugs and toxins in the differential diagnosis. And in fact, in the United States, drugs and toxins are a much more common cause of acute liver failure now than viral hepatitis. Other entities to think about are autoimmune hepatitis, ischemic hepatitis, and Wilson disease. And sometimes the biochemical presentation can be distinctive in each of these. For example, the sky-high aminotransferase levels over 5,000 in ischemic hepatitis and an acetaminophen toxicity, which you usually don't see in viral hepatitis. There are some biochemical mimics as well. And there's a differential diagnosis to chronic hepatitis, including drugs and toxins, autoimmune hepatitis, and Wilson disease. And you may need to think about other causes of elevated liver enzymes. So a brief overview of the diagnosis of the major hepatitis viruses A, B, and C. I think you all know that the diagnostic marker for hepatitis A is the IgM anti-HAV. That's the acute phase antibody. There is no serologic test for IgG anti-HAV, so we surmise immunity or infer immunity by having a positive total anti-HAV and a negative IgM anti-HAV. Hepatitis B is a bit more complicated. The hepatitis B surface antigen is usually positive in acute or chronic disease, and the distinction is made by using the presence or absence of IgM anti-hepatitis B core antigen. Now, the core antigen does not circulate during infection, but the antibody appears. And again, there's no IgG anti-core test, but you infer that by having a positive total and a negative IgM anti-core. You don't need the E antigen or the HBV DNA to make the diagnosis of acute or chronic hepatitis B, but you need them to stage the chronic hepatitis B infection and determine whether treatment is indicated. Hepatitis C, you have to keep in mind that the antibody appears late in the course, and so you really have to test for HCV RNA to make the diagnosis of acute hepatitis C. Generally, we don't test for hepatitis D or E except in special circumstances, and the antibodies are less standardized for these viruses. So let's start with hepatitis A. I'll focus on what's new. And what's new is that the incidence is increasing. Ever since 2017, we've seen a rise in the number of reported cases in the United States. And like many trends, this started in California among the homeless population of San Diego, and then it spread eastward throughout a lot of the United States, so that by the end of 2020, the outbreak had extended to 33 states. Injection drug use was a factor in this development. Now notice the hepatitis A vaccine had been introduced in 1995, and with routine vaccination of children, which became a requirement in 2006, the incidence had gone down considerably. There's a predominance of hepatitis A infections in the western part of the United States, as shown in this slide. And I think you're all familiar with transmission by the fecal-oral route, often from contaminated food or water. Hepatitis A is responsible for common source outbreaks, but interestingly, we used to blame infected restaurant workers for being the source of an outbreak. We now know that if they take standard precautions, even if infected, that such transmissions are rare. So usually it's the food or the water that someone eats that's contaminated and not transfer from an infected restaurant worker. In the early 2000s, travel to endemic areas became a predominant cause of infection, but this has sort of settled down, particularly in the COVID era when there's no travel. Close personal contact is a risk factor, and we used to see a lot of outbreaks in daycare centers, but now children are vaccinated. Bloodborne infection is rare, but it's the sort of lifestyle of injection drug users that leads to transmission. We now recognize clinical variants of HAV infection. For example, a percentage of people develop very high alkaline phosphatase levels, and in addition to jaundice, that can actually mimic biochemically biliary obstruction. This always resolves because hepatitis A always resolves. There can be a relapsing course, and this seems to be associated with an HLA haplotype, so that the IgM anti-HAV can come and go, and the ALT peaks can come and go 2 or 3 times over the course of a year, but recovery is always the rule. Acute liver failure is uncommon with hepatitis A and is more common in people over age 40 than in younger people. We can prevent hepatitis A quite readily. There are 2 commercially available vaccines, and then there's a formulation in which hepatitis A vaccine is combined with a hepatitis B vaccine. In the United States, everyone eventually will be immunized. So these are the latest recommendations from the CDC on vaccinating people with to prevent hepatitis A. Routine vaccination of children is now recommended, and if they've missed that, then catch-up vaccination during adolescence. Then there's a focus recently on adults who may be at particular risk of a severe infection if they acquire hepatitis A, or who are particularly prone to infection. One of the target groups are pregnant women identified as being at high risk because of international travel, adoption, or homelessness. You all know that a shot of immunoglobulin is given to household contacts of people with hepatitis A to prevent infection. And then if they haven't been vaccinated, they receive the vaccine. New data suggests that in immunocompetent people between the ages of 1 and 40, just starting the vaccine series is sufficient for post-exposure prophylaxis. So that's hepatitis A. Not a lot new, but I thought those were some interesting points. Hepatitis B is more interesting. And I used to say that it was my most interesting object of study other than the lowly intern. So the hepatitis A vaccine was introduced in 1982. Screening of pregnant women for hepatitis B was introduced in 1988. Routine infant immunization started in the early 90s and then was extended to adolescents. And so the incidence of acute hepatitis B declined in the United States. But it's still common, and it's particularly common in endemic areas such as Southeast Asia and Sub-Saharan Africa. A lot of the world has hepatitis B or has been exposed. About 2 billion people with past or current infection. And of those, about 250 million have active infection. And these people are at risk of progressive liver disease, including cirrhosis and hepatocellular carcinoma. There are still 2,000 deaths a year in the United States due to hepatitis B. So this is a percutaneous and sexually transmitted virus, and it can be acquired at birth at the time of delivery. But in many cases, we don't know what has caused the infection. We surmise that some people acquired it early in life from an infected parent, or at the time of birth from an infected mother, or from in childhood playing with infected friends. But in many cases, we don't know. Another interesting aspect of hepatitis B is that there are extrahepatic manifestations. And one of the more celebrated complications has always been polyarteritis nodosa. But interestingly, with the advent of vaccination, the frequency of polyarteritis nodosa due to hepatitis B has declined in developed countries, although not in developing countries. And so whereas it used to, polyarteritis nodosa used to be associated with hepatitis B in 30 to 40% of cases, it's associated with very few cases in the United States nowadays. Hepatitis B is also a cause of membranous glomerulonephritis. Now, I think serologic diagnosis of hepatitis B has always been a bit of a mystery to people, but it actually is not that hard. Generally, infected people have the surface antigen, and they always have anticore antibody. During the acute phase, it's an IgM anticore, and during the chronic phase, or after recovery and the clearance of surface antigen, there's an IgG anticore, which, as I said, is a positive total negative IgM. Now, E antigen always appears during the early part of the infection, so you don't have to test for it. But in people who become chronic carriers, it may persist and ultimately disappear. Anti-HBs alone indicates immunity, but when it's combined with the IgG anticore, it indicates that someone had a natural infection that resolved. So the risk of chronic hepatitis B is entirely age-related. A neonate who acquires hepatitis B at the time of birth has a 90% chance of becoming a chronic carrier. An adult who is immunocompetent and acquires hepatitis B and develops acute hepatitis B will almost always clear the virus, only a 1 to 2% chance of chronic infection. That's why there's such a large reservoir of chronic carriers in the world, because they've acquired it early in life. Now, a major focus of study has been the natural history of chronic hepatitis B infection. Traditionally, it's been divided into 4 stages called immune tolerance, immune clearance, inactive carrier, and reactivation. For reasons not entirely clear for me, these have been rechristened to a very confusing set of designations: hepatitis B E antigen positive chronic HBV infection, E antigen positive chronic hepatitis B, E antigen negative chronic HBV infection, and E antigen negative chronic hepatitis B. I think the old classification is more useful because it tells you a little about the pathogenesis. A 5th phase has been added, resolved HBV infection, because some chronic carriers eventually do become HBsAg negative. And we also call that a functional cure, and I'll tell you why in a moment. So the infants who acquire hepatitis B are immune tolerant. They tend to have high HBV DNA levels, but they don't have much in the way of liver inflammation because there's no immune response. They may have little blips of ALT elevations, and these little periods of inflammation may contribute over time to the development of cirrhosis, but for the most part, they're living in symbiosis with the virus. And we don't treat them because treatment doesn't seem to help. Active disease is marked by E antigen positivity and high ALT levels, and this generally sets the stage for clearance of E antigen, but that may take years or decades. And when E clears, the HBV DNA comes down, the ALT returns to normal, and the anti-E antibody appears. That is considered inactive, the inactive carrier stage. And most people in the world, particularly in Asia, live in that phase. But either spontaneously or as a result of immunosuppression, the virus can reactivate. And a lot of interest in what precipitates reactivation in the setting of cancer therapy or immunosuppression. So this is a little complicated, but we generally divide the risk of reactivation into low, moderate, and high. And the one thing I want you to remember is people with an isolated anti-core antibody, even if they don't have surface antigen, are also at risk of reactivation. The virus is lingering there. And the reason that is this is a DNA virus, and it tends to incorporate into the DNA of the host hepatocyte. So even if the surface antigen is gone and there's no viral markers being produced, the virus is there. So some drugs are associated with a fairly low risk and others with a much higher risk. Rituximab, for example, is associated with the highest risk in other anti-CD20 drugs. So in the moderate to high group, we generally start antiviral therapy before treatment of with the immunosuppressant or cancer drug is initiated. With a low risk group, such as someone going on azathioprine, we might just monitor them very closely and initiate therapy at the first sign of activation. But you really have to be careful about this because some of these reactivations can be severe and result in death. So the hottest topic now is functional cure. Some people go through these stages and lose the surface antigen, and they become HBV DNA negative. But the virus is lingering in the liver, and we now are beginning to have markers that tell us if the virus is in the liver or to what degree it's likely to reactivate. One such marker is a hepatitis B core-related antigen, which is not commercially available. Another is HBV RNA. So there's a lot of work going on in this. And as we develop new therapies for hepatitis B, beyond the conventional treatments we use now to suppress the virus, we'll be very interested in using these markers to see if we can permanently suppress hepatitis B, creating what's called a functional cure. So the reason we're so interested in HBV DNA is that it correlates with the risk of hepatocellular carcinoma. Even in E-negative, normal ALT, non-cirrhotic patients, the greater the HBV DNA, the greater the risk of hepatocellular carcinoma, as well as cirrhosis. There are other risk factors, the most important being cirrhosis itself. But hepatitis B is a virus, unlike hepatitis C, that can cause liver cancer even in the absence of cirrhosis. So the goals of therapy right now are just to suppress the HBV DNA, try to get rid of the antigen if it's present, hopefully clear HBsAg, but that doesn't usually happen, and have the downstream benefit in reducing progression of liver disease. So our treatments now are suppressive, but they are tremendously effective. We can basically always suppress hepatitis B if it's active. So these are the drugs that have been used over the years, starting with interferon. For many years, that's what we used. And then the nucleoside and nucleotide analogs came along. And the more recent ones, particularly entecavir and tenofovir, are very effective in suppressing hepatitis B. There are now two formulations of tenofovir. The latest one introduced a few years ago, tenofovir alafenamide, is associated with a slightly lower risk of bone and renal toxicity than the original formulation, but even for that drug, the risk is low. The older drugs, lamivudine, adefovir, and telbivudine, are still used in some parts of the world or for some indications. So entecavir and tenofovir are much more effective in suppressing hepatitis B, for example, in E-positive patients. This is after 1 year, and the rate rises with continued therapy. But the problem is you have to give these long-term. For E-negative hepatitis B, the starting DNA levels are lower than in E-positive, and entecavir and tenofovir almost invariably suppress these levels. But E-antigen to E-antibody seroconversion doesn't always occur. In fact, it doesn't occur in most people. So these drugs have to be given indefinitely, and surface antigen clearance is uncommon. So there are 5 sets of criteria for when to treat with an antiviral agent. We may treat E antigen or E antigen positive or E antigen negative patients. For both cases, we look for active disease as demonstrated by elevated ALT or a biopsy showing liver inflammation. The cutoff for treatment based on HBV DNA varies between E antigen positive and E antigen negative, but you have to consider all the factors in making a decision. So these are guidelines, but not absolute rules. So this is our current scheme for E antigen positive patients. You treat until E antigen to E antibody seroconversion, and then 6 to 12 months in addition to that. Usually I treat for another 12 months. But if the patient already has cirrhosis, you don't stop, you treat until they clear hepatitis B surface antigen, recognizing that they probably won't. In Asian people, there tends to be a high rate of relapse when you stop treatment, even after that additional 6 to 12 months. So for some of those patients, we decide just not to stop it. E antigen negative patients are a bit harder because there's no endpoint, there's no seroconversion. They're already E negative and anti-E positive. So these people we tend to treat indefinitely, but there are some emerging studies to suggest that you may try stopping after several years, and you could monitor quantitative hepatitis B surface antigen levels to guide your decision making. So there are now 3 hepatitis B vaccines available. It is a routine vaccine for infancy and is used in adults at risk for infection. It can be started post-exposure in people who are not immune in combination with a hepatitis B immune globulin for immediate protection. And one caveat is that we like to bring the level of HBV DNA down in pregnant women before they deliver, even though we're going to immunize the infant starting in the delivery room of any carrier mother. And so often for carrier mothers, we will give an antiviral agent in the 3rd trimester of pregnancy to get the HBV DNA level lower and reduce the risk of transmission even further than vaccination does alone. The latest vaccine is Hepatis, just introduced. It has its own immune adjuvant, and it only has to be given in 2 doses rather than the 3 that the other 2 required. So I'm going to end with one slide here on hepatitis D. Hepatitis D cannot infect you unless you have hepatitis B. It can either do it simultaneously, in which the natural history is no different between combination infection and hepatitis B alone, except you might see 2 peaks of ALT, or it can super infect a hepatitis B carrier and then accelerate the progression of chronic infection. So it turns out the original name for hepatitis D was hepatitis delta. And Delta Airlines has followed this field closely in an uncanny way. And they have kept changing their slogans to match progress in the field. So they used to say, Delta is ready when you are, when we recognize that you can't have D without first having B or getting it simultaneously. Then they said, we love to fly, and it shows. And it turned out in the United States, the people who predominantly acquired hepatitis D infection were intravenous drug users. We love to fly, and it shows. Now, there were endemic parts of the world in Mediterranean countries like Romania as well. And then they had a slogan that said, the Delta gets you there. So having D on top of B accelerates the progression to cirrhosis and triples the risk of hepatocellular carcinoma. So there are some potential treatments. The only one available is PEG interferon, not a very good drug with all its side effects, and you probably have to give it indefinitely, and it isn't reliable. Then there are some newer drugs on the horizon, a farnesyl transferase inhibitor called lanafenib, and an entry inhibitor, bulevirtide, but these are undergoing studies now. So that's my talk. I think I finished just on time, and if there's any time, I'm happy to answer questions.
Thanks, Larry, so much. I don't see any questions in the chat box. One question that tends to vex us primary care docs a lot is we get patients who go through the series of hepatitis B vaccination, and then some job or some university or some medical school makes them prove antibodies. They don't have it. It used to be that we used to have to give the whole series. I think now the recommendation has changed to give one, and then they want another test and they still don't have it. Any suggestions for us out here trying to fog through that?
So 5% of people will not respond to the vaccine. And some of this is genetic. There is an HLA association. Obesity may be a factor and so on, but 5% are not going to respond. I don't know if you vaccinate them with Heplisav, whether that will increase the possibility of a response. There were all sorts of regimens recommended in the past: subcutaneous infection, 4 shots instead of 3, accelerated administration. None of it was terribly reliable. Some people are just not going to develop immunity to hepatitis B.
So even if they're not showing the antibodies, then they're not immune. So if they do, if they are working in a hospital setting, say, they should be aware that they're not covered for Hep B.
Yes, I mean, they should still take all the usual precautions, and we don't restrict them from doing medical work, for example, but they're not going to be immune.
Excellent. Well, thanks again. Thanks for the time, and thanks for the great lecture. Hope everyone enjoyed this week, and hope everyone has a nice weekend. The sun's shining. Get out there and get some vitamin D exposure, and we'll see everyone next week. Thanks again. See ya.
Bye. Thank you.